laparoscopically by clipping and by using the patient improve with the surgery, but the medical treatment doesn't have any. In the moderate to severe endometriosis, the latest treatment IVF is. Okay? It doesn't have to do the surgery. It is the IVF and ICSI, they have better results if the moderate or the severe endometriosis. What about large endometrioma? The picture goes both ways. You remove and the ovarian reserve decreases, and if you leave it, also interferes with the ovulation, poor quality of poor implantation, so pregnancy rates all the way they are in the patients suffering from endometriosis. Yes, sir. What about unexplained fertility? What should do? Okay. Unexplained fertility, when the patients, all the tests are normal and they still fail to conceive. The 10% of the patients, they fall into this category. And they have waited at least for the 2 years and they still fail to conceive. Now, what you can offer to them is the ovulation induction, that is a chloroquine straight. Don't go beyond 12 weeks and assess the transvaginal ultrasonography on 12 day or day 14 to see if the follicle is formed. Then she can take at home. She doesn't need to repeat follow-up with the ultrasound. Okay? So, what we can do, we can offer them no treatment, then the pregnancy is 2.6%, with IUI without any ovulation induction 3.8%, with clomiphene slightly increases the pregnancy rate. And you can see with gradocopin IUI, the pregnancy rate in unexplained fertility can be 70.1%, with IVF it can be 20.7%. Yes, sir. So, intrauterine insemination, it is the success rate lies between 15 to 20%. Okay, then. So, what are the indications? In the case of the female, we already said that unexplained fertility, there is cervical factor, that it is too tightly closed and you carry out under anesthesia, and husband is away for the longer period of the time and he visits, you want to make it certain that there is pregnancy, then you can carry out this. And then if the patient is suffering from mild endometriosis, then intrauterine insemination helps. Or patient has ovulatory problem, again IUI is. What about the male? Indication the male is the mild weight factor. Okay? And then there is the impossibility. There is some problem with the male, he cannot deposit, physical disability, cannot deposit the semen in the vagina, or there is retrograde ejaculation, then IUI is the answer to that. So thumb rule is control ovarian stimulation plus IUI is effective. It works in first 3 or 4 cycles. Don't repeat IUI again and again. Don't waste time. IVF after 3 failed IUI attempts, they should be IVF or ICSI. So what is IVF in ICSI? There is the sperm and the ova, they meet outside. Okay? And then you put it in the incubator and after embryo you place it. So what are the indications of these? Blocked tubes, severe male factor, unexplained fertility is also, severe endometriosis, and failure to conceive. The next aggressive treatment you have done, then the patient should be remembered. And as soon as possible, before she reaches 35 years of age, because her fertility potentials, they go on decreasing. Her number of follicles, they fall by half when she reaches 35 or beyond. So, what is the protocol? In the natural cycle we can follow, or we can give OCPs in the patient who have irregular cycle, so that they have definite bleeding. Then they are giving granulopathy releasing hormone, okay? And then granulopathy for the ovarian stimulation. Then egg retrieval is carried out, then the transfer is carried out. So this is the transvaginal ultrasound for the egg retrieval. The procedure is being carried out. Yes? Is it done? Okay? So intracytoplasmic is that is, it was by accident it was discovered in the Belgian IVF lab. Now all the forms of severe male factor infertility are treated by the intracytoplasmic sperm injection. So the timing of embryo transfer, that is day 3, you can see the beautiful corolla, 8 cell space, and the blastocyst is the day 5 or 6 we carry it. latest is that is better results that are obtained with the blastocyst transfer. And this is the embryo transfer, which is carried out under ultrasound guidance, pelvic ultrasound with full black. You don't need any anesthesia, the service is alright, we already assess it. The patient is coming, and this was at Shalimar Hospital. The patient conceived over here, and it was twin pregnancy. It was real male factor, and in the male, the visa was carried out, and the full term babies we did cesarean section, and this is our team. Pediatrician is this, and nursing staff in our hospital administration. Next. We are also running an infertility clinic at Shalimar Hospital. This data is of 100 patients that we collected, and in this we can see that is the patient usually report when they are already 32, 46 to 32. We can see 38% of the patient reported in that. And the BMI, you can see that is 34% of patients already have more than 30. So our society, I don't know the BMI is, when they present, it is already high. Primary infertility, 63% of the patients, they were primary infertility, and secondary infertility was present in 37. You can see the biggest burden on gynecologists is because of the PCO. That is 47% of the patients, they have PCO. And the thyroid disorders were present in 11%. The blockage combined that was present about 12%. Endometriosis 10%, and the male factors you can see we have divided into an azo, oligo, and the astigmatism. Then 8% of the patient they had unexplained. So the points to remember is one satisfied patient is worth thousands of the guidelines and the protocol. Next. So the same patient in the theatre, then we carry a cesarean section, and he had 2 full-term female babies. And hopefully he is on his way, he is bringing his baby, so that you can also meet them. Any questions you want to ask?
Any question?
मैडम एक पायलट जो जख्मी है मेल पेशेंट उसके लिए कर सकते हैं
Vasectomy is very successful. The results are very good. And of course, the other physical characteristics is age, because male age also has his BMI, and he is not involved in that is smoking, alcohol. Is actually very good.
Sympathetic is what?
Sympathetic is what? We have already talked about that is azoospermia. Azoospermia, the main factor. We have to find out the cause. This is hypothalamic pituitary. It is the statistical failure. Okay? Or what is the problem? It is obstruction. There are 3.
Sometimes there was sympathetic is what?
Of course, exactly उसका ब्रोंकिस कर दिया, उसको स्पर्म तो आई.
Sympathetic is what?
In the semen analysis, they won't be any because you have cut off the passage. एज़ोस्पर्मिया उसको होगा. और आपने जनरली उसका ब्लॉक कर दिया. ठीक है, उसके टेस्ट सारे ठीक है. आप उसकी टीमों को दोबारा एनालाइज कर दें तो देखिए.
These patients develop anti-sperm antibodies.
Anti-sperm antibodies. After that, this semen analysis will be carried out, and if the 50% of the sperms they don't have any this antibody, the baby we can see. And then the role is coming about this steroids that they may have role in anti-sperm. They do develop, but if the 50% of semen is alright, they don't have this, then they can.
Thank you, Dr. Sophia, for a very informative lecture that is on evaluation of subfertility. Now I request कि Dr. Sophia यहीं पर हमारे पास स्टेज पे मैम प्लीज आप स्टेज पे आइएगा हमारे साथ. एक पेशेंट है हमारे साथ चूँकि दे हैव टू गो बेबी को थोड़ा सा कुछ इशू भी है वेदर चेंजेस के हवाले से. या एग्जैक्टली आइए बात कर लीजिएगा प्लीज. ये पेशेंट है, हम इसे सेरेमनी छोटी सी करना चाहते हैं क्योंकि ऑस्ट्रेलियन कॉन्सेप्ट का एक रूल है, हमारी एक रवायत है कि जो पेशेंट्स यहाँ पे पॉजिटिव होते हैं तो हम उनको बुला के सेरेमनी करते हैं, गिफ्ट्स देते हैं और बेस्ट विशेस देते हैं। इसका मकसद सिर्फ यही होता है कि जो दूसरे पेशेंट्स भी हैं वो भी इससे थोड़ा सा लेवल उनका बूस्ट होता है कि ट्रीटमेंट इज़ पॉसिबल रिगार्डिंग इनफर्टिलिटी। पेशेंट में मैं देख सकता हूँ उनको मेरे ख्याल से, तो मैं सहज से रिक्वेस्ट करूँगा अपनी बेबी के साथ काइंडली आ जाएँ। बेसिकली डॉक्टर पाशा हमारे कंसल्टेंट हैं, उनके पेशेंट हैं। डॉक्टर सफिया की भी पेशेंट है, अनफॉर्चुनेटली ड्यू सम रीजन दे आर अनएबल टू कम। इनका मैं आपको बता देता हूँ कि बेसिकली ये मेडिसिन पॉजिटिव है, IVF की जरूरत नहीं पड़ी थी। सर आप फैमिली आ जाइए यहाँ पे, और मैं रिक्वेस्ट करूँगा सर एमर जो डायरेक्टर ऑस्ट्रेलियन काउंसिल वो भी स्टेज पे खड़े हों हमारे साथ। और सबसे पहले तो इनके बेबी के लिए गिफ्ट है और मैं डॉक्टर सफिया से रिक्वेस्ट करूँगा कि वो उनको फॉरवर्ड करें। ख़वातीन हज़रात, ये पेशेंट मेडिसिन पॉजिटिव है, IVF नहीं अप्लाई किया गया। आप लोग को बताने का मकसद है कि वो कि ऑस्ट्रेलियन काउंसिल एक IVF सेंटर है, बट डजंट मीन कि यहाँ पे IVF ही किया जाता है। थोड़ी सी मैनेजमेंट जो भी डॉक्टर सफिया का टॉपिक भी है कि वी मैनेज ऐसे पेशेंट्स को जिनको ज़रूरत होती है तो दे कैन कंसीव नेचुरली। सो दिस इज़ वन ऑफ द एग्जांपल ऑफ दैट केसेस। तो आपसे मैं रिक्वेस्ट करना चाहती कि थोड़ा सा अपना फीडबैक शेयर करें जब आप यहाँ पर आई थी और कैसा लगा आपको एंड हाउ वाज द ट्रीटमेंट, थोड़ा सा डॉक्टर्स को भी।
अस्सलाम वालेकुम। मैंने यहाँ पे मुझे बहुत अच्छा रिस्पॉन्स मिला। मैंने काफ़ी जगह चेक करवाया बट मुझे कहीं से अच्छा रिस्पॉन्स नहीं मिला, मतलब कि ना उम्मीद हो गया क्या। तो फिर मुझे किसी ने डॉक्टर पाशा का बताया तो मैं यहाँ आई और मेरा चंद महीनों में ही कंसीव मैंने कर लिया। तो मुझे बहुत अच्छा रिस्पॉन्स मिला और मुझे बहुत ज़्यादा खुशी है इसकी इदारे की कि ये यहाँ पे हमारा हुआ। और यहाँ पे काफ़ी लोगों को, ये नहीं कि मुझे, काफ़ी लोग ऐसे हैं जो ना उम्मीद थे और जहाँ जो आए और उन्हें काफ़ी अच्छा रिस्पॉन्स मिला यहाँ से।
अब शादी कितने अर्सा बाद हुई?
हमारा शादी के कम ही अर्सा हुआ था, अभी 7th मंथ ही हुआ था जी।
इसमें क्या केस क्या था और what medical help was given?
डॉक्टर पाशा इज बिजी द केस, इनके पेशेंट थे वो आपको ज़्यादा बेहतर बता सकते हैं, बट वो रीज़न वाज कि थोड़ा सा मेल इनफर्टिलिटी आता है, फीमेल आता है, थोड़ा मैनेज किया गया है। लेकिन डॉक्टर पाशा चुके नहीं तो ही कैन एक्सप्लेन बेटर। एनीवेज थैंक यू सो वेरी मच, आई अप्रिशिएट इट। डॉक्टर सफिया मैं चूँकि डॉक्टर सफिया की भी एक केस है, शी हैज़ टू गो, तो मैं रिक्वेस्ट करना चाहूँगा डॉक्टर सफिया आप इजाज़त करेंगे स्टेज पे। और डॉक्टर तारिक भैया सर चीफ गेस्ट हमारे आज के और प्रेसिडेंट है पाकिस्तान के एडमिट फिजिशियन। मैं चाहूँगा कि डॉक्टर सफिया को स्विंगर प्रेजेंट करें बिकॉज शी हैज़ टू गो, शी हैज़ अ केस।
मैं भी तो देखिए
बहुत शुक्रिया डॉक्टर, आपका थैंक यू डॉक्टर सफिया फॉर द लवली एंड वेरी इंटरेक्टिव इंफॉर्मेशन अबाउट इवैल्यूएशन। दो ही लेक्चर्स हमारे पास हैं, एक लेक्चर हमारा जो है वो पीसीओ से रिलेटेड है जो कि लास्ट होगा, लेकिन उससे पहले मैं रिक्वेस्ट करना चाहूँगा डायरेक्टर ऑफ ऑस्ट्रेलियन काउंसिल इनफर्टिलिटी मेडिकल सेंटर मिस्टर अहमद सजाद, डायरेक्टर हैं हमारे ऑस्ट्रेलियन काउंसिल के, और थोड़ा सा ब्रीफ इंफॉर्मेशन देंगे ऑस्ट्रेलियन काउंसिल के हवाले से।
Assalamu alaikum, Dr. Tariq Mahmood, a very warm welcome. Our guest of honor, Dr. Tariq is, as most of you would know, is the president of Academy of Physicians, Pakistan. I'm really pleased. We have had so many lectures like, today, before, and the audience who are here today is the one most I have seen who has come on time. So I'm really pleased about that. So we were still late that we started, but not as late as we normally start. So really pleased about it. Can you please switch off these lights? Thanks. So my presentation is a brief one. It will take 10 minutes just to introduce you to Australian concept and how we started and where we are now and what we are going to do in the future. So we have been around for 20 years. This year is our 20th anniversary. So it has been a long journey. We have the largest IVF branch network in Pakistan. We were responsible for the first frozen embryo transfer baby of Pakistan. So we have a constant focus on quality and managing an IVF center, is not easy. So you need to be on top of your quality assurance program. So we constantly deliver high success rate, and I would like to announce today our embryologists have, announced for February our success rate is 60%. And it's a huge, I called Dr. Sajjad, he's on his way, he's coming to Lahore today, so, he's very happy, so there's nothing better in terms of news, having a success rate of 60%. This is a snapshot of our branch network. We are looking at opening a branch in Peshawar also this year, inshallah, and Quetta, a full-fledged IVF center. In terms of our timeline, started in 1998 at Karachi. Year 2000, we already started freezing, the embryos, and the first frozen embryo transfer baby was born in 2000. And so we realized a lot of patients even today, they come from Afghanistan, and a lot of them come from overseas as well. So back in those days at Karachi, we could see that infertility was not spoken about very openly. So we went to the media. We were the first to go to the media and advertise on radio and TV. And then we decided we will open branches. So this is the vision and thought behind, going to areas in Pakistan where people cannot travel, like Rahim Yar Khan. Also this month we had the first ICSI positive result. So I'm really pleased because I was involved from day one, opening the center last year. So it is a sub-center where patient is stimulated and then triggered, and then they come to Lahore for pickup and embryo transfer. So our efforts, last Ramadan we started, so it has taken us 6 months. We had a few ICSI attempts, I think 4 of them, so we've got the first one just positive. So we will continue to expand into areas and raise awareness in the community. So 2009 we opened up in Lahore. In this building we, I think, moved in 2012. In Islamabad and Quetta we had sub-centers in 2010, 2011 Multan. 2012, as I said, moved into this building and also started offering PGD. 2013 started PGD at Lahore. 2014 Gujranwala and Sakkar. 2015 and 16 we launched PGD at Islamabad as well. And 2017 Rahim Yar Khan and Faisalabad. So 2018, as currently we are looking at genetic testing. Infertility IVF result typically internationally they have been around 30, 35, 40% based on different age bands. So with the latest advancement in genetics, we have seen in America and Europe now, IVF centers are reporting up to 70-80% success rates. And it has been possible through genetic testing. So we have signed an agreement now with a company based in Spain, and we have started now sending some samples of our patients from Pakistan. And hopefully this will improve the success rates even further. So I will talk about what tests we are doing. As part of our quality assurance program, we have Primovision tool that we use. Traditionally, what used to happen before in the labs, when we inject the sperm into the ovum and it starts fertilizing. So after 24 hours, we take it out from the incubator and look under the microscope with our naked eye. So with this Primovision tool, we have a screen that you can see. It gives us more detail that we can see from a normal microscope. So not exposing the embryo again and again over the 3 to 5 days it grows is helping the success rate even further. We now have these in Karachi, Lahore and Islamabad. As part of quality assurance program, and our origin has roots back to Australia. So we opened up the center in partnership with Australia, and over the last 20 years, Australian scientists have regularly visited us. In this picture is Adrienne. She is our IVF consultant and scientific advisor. Any issue that we have, any troubleshooting, we always speak to Adrienne. So this is her picture upstairs in our embryology lab, talking to our embryologists and OT staff. So just briefly, back in 1978, the first baby, Louis Brown, was born. It had a huge impact, and it was a breakthrough, in the world of science and infertility. So by the year 2010, 6 million babies had been born, and Sir Bob Edward was also awarded. I think he passed away in 2012, but he was awarded Nobel Prize in 2010. So here he is with Louis Brown in this picture, Sir Bob Edward. So recently, my mom and dad, they were in US, for the ASRM, and they were lucky to meet Louis Brown during their visit. This is Dr. Sajjad talking to Louis Brown during his visit. And she also gave a special message to Dr. Sajjad. Here it is in her handwriting, so I think it was a blessing to meet with that first baby because it's part of history. Louis Brown will always be the first baby born through that tube. So she wants us to keep making healthy babies, and I think we'll continue to try that, and Allah will bless, inshallah. Stages of reproductive cycles, pre-conception, pre-implantation. So this is quickly sharing with you what tests we are now offering in the genetic side. So there is a test called CGT. Each of these tests, would require a separate presentation. So I would just, at a very high level, share what they are. Pre-implantation PGS. We are offering PGD, SAT, sperm and haploidy test. ERA is the endometrium receptivity analysis. So it tells you what is the right implantation window for a different female. So it's not the same for all females. This is what genetics has told us. And then some of these are prenatal, like NACE is non-invasive test, POC, and a neonatal one is WES. So all these tests are now available through Australian Concept. We have been sending samples from Lahore. Currently there's some issue with DHL, so we have to send it through Karachi. But we are working with DHL, as I think it is very important for us to bring, the latest technology that we can offer to our patients. So we are working with DHL to resolve the issue, but right now we are able to still send via Karachi. So Australian Concept is offering all these tests that I mentioned, and that's it for me. This is one of my favorite slides, all the babies that have been born through Australian Concept. Thank you very much for listening.
Thank you, Mr. Ahmed. Thank you for kind introduction about Australian Concept Infertility Medical Center. Ladies and gentlemen, now move to the last topic, and again it's very important regarding polycystic ovarian syndrome. Now I want to invite one of our consultant gynecologists and infertility specialist, Professor Nazli Hamid Saiba, to please come on stage and present her presentation.
Assalamu alaikum. It's very, very nice gathering today, filled up till the back. Not a very good time to speak though, because it's already 4 and you are waiting for the lunch, but I'll try to be brief and crisp with you. I am Professor Nazli. I am working currently at Shalimar Hospital. Dr. Safia is working with me as my associate. We have recently started our regular urogynecology and reproductive endocrinology clinic over there. urogynecology, we are doing full-fledged, and in infertility, we are offering up till IUI there, and whatever next we come here to do for assisted conception. So you are all welcome to have a brochure. I've dropped the brochures at the reception. You can have a contact number there, and if you want to refer the patients, you can refer to us. So I've got my qualifications from UK in assisted conception and minimal access surgery diploma from France and in urogynecology from Singapore. The purpose of today's presentation is that we want to make you understand the most plausible causes which can contribute towards recent increase in polycystic ovarian syndrome in our patients, and can we possibly prevent it, because it is coming like an epidemic. Every other girl that you're seeing is suffering from PCOS. So, and if it is preventable, then what are the appropriate current strategies to handle it, to help our population, and why we are so concerned about it, because it is the commonest cause of anovulation in any infertile couple. It affects up till 25% of the female in reproductive age women, so that means that practically every fourth woman is suffering from PCOS. And 70% of that group will experience an infertility due to ovulatory dysfunction. So every fourth woman is being affected, and out of them, the 3/4 of the chunk is going to have ovulatory dysfunction and infertility due to that. So these are the two gentlemen, Stein and Leventhal. They were the initial ones. If you remember from your medical college experience, we used to call it Stein-Leventhal syndrome at that time, and ovarian wedge resection used to be done at that time, which has now been made obsolete. This is just a slide from the first paper which was presented on PCOS. And initially what used to be done was that, both ovaries were partly removed, which was called ovarian wedge resection, which is now a completely obsolete procedure. But, these were the gentlemen who introduced it. The criteria of diagnosis were defined in 1990 and revised in 2003. So for clarity, I'll just focus on this 2003 criteria, because this is the one which is currently being followed. So the consensus explains that at least 2 of the 3 features should be present. Number 1, clinical or biochemical hyperandrogenism. Hyperandrogenism is not just hirsutism. Recession of hairline and greasy skin or acne, all the features, virilization or the hoarsening of voice, they all come in hyperandrogenism. Oligo or anovulation, and then polycystic ovarian picture, the morphology. So any 2 of the 3 features, if they are present, that is enough to diagnose polycystic ovarian syndrome. And then it can exist in 4 different categories. You see the type A, which is the classical picture, all the 3 things are present. Hyperandrogenism is present, ovarian dysfunction is present, and when you see on scan, the polycystic ovarian morphology is also seen. इन्हीं तीनों को आप 2 different combinations में ले तो type B, type C, type D है. Type B जो है, that is classical picture of hyperandrogenism and ovulatory dysfunction, लेकिन scan में PCO की picture आपको इसमें नहीं मिल रही. So it is not just diagnosed on scan. On the other hand, in type C, you see the ovarian morphology of PCO on the scan, and you see hyperandrogenism, that these patients are ovulating normally. So this is that 30% of the group which is not having ovulatory dysfunction. And type D is those who have a polycystic ovarian morphology and ovulatory dysfunction, but overall they do not have the symptoms of or signs of hyperandrogenism. So it can exist, in different combinations. The main thing is, it's not just a fertility concern. It is a metabolic disorder which has got other lifelong sequelae. It is a dysfunction of the lipid metabolism. It is a dysfunction of glucose metabolism. It can predispose to diabetes and chronic vascular disease in the long term, and also to various types of malignancies, including endometrial cancer in the long run. So it is important to be treated. It can result in impaired glucose tolerance or type 2 diabetes mellitus in about 40% of the patients who have PCOS by the 4th decade of their life. When they cross their 30s and they are in the 4th decade, 40% of them will have type 2 diabetes. And dyslipidemia, like low HDL, which is the good lipids, and high LDL, which is the bad one, and high triglycerides. So These patients are also at higher risk for non-alcoholic fatty liver disease. PCOS has also been linked with increased mass of left ventricular muscle, endothelial dysfunction, artificial stiffness of vessels. Patients are more susceptible to subclinical vascular disease than normal women, and coronary artery calcification because of interval and medial thickness. So you see, PCOS is not just infertility or not just irregular cycles. It is much more than that, and should be taken care of. And a long-term 2.7-fold increased risk for endometrial cancer versus the general population. Because आपको पता है obesity and hypertension, they are the risk factors for endometrial cancer, and both of them can occur very frequently in patients with PCOS. So all the three factors add up together and they trigger endometrial cancer. Patients can have psychosocial issues like depression, anxiety, and bipolar disorders depending on the severity of clinical signs and symptoms in her. हमने करना क्या है पेशेंट्स के लिए हमारा चैलेंज क्या है when we are talking about such a wide range of symptoms and what's a wide range of paradigm of symptoms with which they can present. It depends whether the patient is presenting to us at a young age when she's either unmarried or very recently married, or she's presenting at an older age group. So it depends what are her concerns. Generally, younger females would present to us with menstrual disorders, hirsutism, or if there is early marriage, then sexual health related issues and infertility may be present. In older age group, apart from this, they would have come to you with pregnancy related complications. If pregnancy is hoti to hai, lekin baar abort ho jati hai. Abortion rate is also very high in PCOS patients. Type 2 diabetes, we already discussed cardiovascular disease and cancer risk. And here you see multidisciplinary approach is more often true for PCOS than for any other disease. आप pediatrics से शुरू होते हैं इसको cover करना, and dermatologist covering acne, then gynecologist, then endocrinologist, diabetologist, and cardiology and genitourinary. So it's a multidisciplinary input, which when we are running a reproductive endocrinology clinic, so geriatrics. So पैथोजेनेसिस है, it is an epigenetic disorder. Epigenetic disorder का क्या मतलब है कि ऐसा disorder जिसकी predisposition genetic है, but वो express होगा कि नहीं, that is being modified by the environmental factor. So this is very important to know because you can't change the genes of a person, but you can very well modify the environmental factors which let that gene play its role. So two genetic loci are present, and what clinically, if the PCOS starts, it results in high LH, hyperandrogenemia, and chronic low-grade inflammation of ovaries. So what environmental factors we are talking about? This is primarily a disease of adolescence. In utero androgenic square of the female fetus is the first thing which can predispose females to PCOS. And then if a patient has, if a girl has early puberty or early adrenarche, then she is more likely to be diagnosed as PCOS in later life. And if combined with that, the menarche is delayed. So the other features of sexual maturity, they come earlier. But the final terminal part of puberty, which is menarche, that is delayed in these patients. When prepubertal obesity is common, so obese children with early puberty have an increased risk of developing metabolic syndrome, METS, metabolic syndrome, and PCOS. This is very important. Childhood obesity में fat cells का overall number increase हो जाता है. So that obesity is very difficult to be treated. So that is very important because we have to address our children right at this age when they are eating so much of processed food, and all the pizza and shawarma products. Adolescents with oligomenorrhea and hyperandrogenism are at increased risk of obesity. So it is both ways. अगर PCOS है तो वो obesity कर रहा है, और अगर obesity है तो वो predisposed. So both of them are augmenting and aggravating each other. Why? Because obesity causes suppressed level of serum hormone binding globulin. Higher free androgen levels are available in the body. It prolongs the follicular phases, causing anovulation, oligomenorrhea, and signs and symptoms typical of hyperandrogenism. And this is also obesity in women. It causes increased circulatory concentration of lipotoxins. These are the toxins which produce inflammation in the ovaries, and they result in ovulatory dysfunction because of granulosa cell toxicity and dysfunction. So weight loss in obese women is the single most important factor which improves their reproductive and metabolic outcomes. And it is so important that you tell the patient कि आप अपना weight अगर सिर्फ by 10% reduce कर लेते हैं. I'm not saying 10 kg, 10%. So if a patient is like 70 kg और आप 10% करें तो it is 7 kg. तो आप से बताइए कि अगर वो 10% reduce करती है तो आपकी जो drugs हैं, जो भी आप intervention करें, that is going to be 50% more effective. So it is 5-fold increase in the success of whatever medication you are giving. Nutrition का role हम plasticizers can cause obesity, altered puberty and ovulatory dysfunction. ये आप जो common household objects जैसे microwave में चीजें plastic के microwave utensils में आप microwave safe plastics use करते हैं, they should not be used. Microwave अगर आप use करें अभी आगे हम देखेंगे कि dry heat in itself increases the toxic products in the food, और अगर वो आपने plastic में इसको गर्म किया तो you enhance it further. So what is this age rage phenomenon? This is advanced glycation end products. It is formed by the combination of carbonyl group from the carbohydrates and amino group from the proteins, and they are toxic products. They can cause cellular damage after deposition in different tissues.